Okay, so I'm delighted to introduce the second part of this session. I'm under the impression that our presenters are remote. Are they with us? Oh, good. Hello.
Hello.
Wonderful. I can see you both now. Thank you for joining. Dr. Vaughan is a clinical psychologist working in psychosis and neuropsychiatry services and an associate professor at University College London. He completed his PhD in cognitive neuropsychiatry in Cardiff and a doctorate in clinical psychology in London. And research interests include cognitive mechanisms of neuropsychiatric disorders and open science approaches to psychiatric research. Dr. Dorothy Wade is a consultant clinical health psychologist in critical care for North East London Foundation Trust and an honorary associate professor at University College London. She is chair of the core network of post-COVID psychologists, and research interests are in psychological aspects of critical care, including delirium. So thank you again for joining us.
Well, thank you very much for the introduction. So it's a real pleasure to be presenting with Dorothy our talk on understanding the mental health impact of COVID-19 on clinical staff. It's worth just giving perhaps a little bit of background about what each of us have been doing during the pandemic. So most of my time I spend as a dreary academic, but I still spend a day in clinical services. Dorothy, do you want to just give a bit of an introduction about what you spend your time doing?
Yeah, sure. Thank you, Vaughan. Yeah, I'm a consultant health psychologist, and I've worked for quite a while in critical care departments. That was pre-pandemic, and then through the pandemic in a couple of different London hospital intensive care units. I'm actually now gone to Chelsea and Westminster Hospital. And that's been really supporting my colleagues, supporting patients who are actually in the intensive care units with COVID, and then follow-up clinics, long COVID clinics after the hospital experience as they recover, and also supporting families. So a bit later in the talk, I'm going to be just giving some feedback from on the ground, what it's been like working as a member of staff in the hospitals, mainly in the London area during the pandemic.
So this talk is really going to do a couple of things, really. The first thing we're going to do is just contrast what's the kind of media and public narrative been regarding the impact on health staff with regard to mental health. We're going to look at evidence from a live meta-analysis that myself and Dorothy have been running on the evidence for the mental health impact of working in the pandemic. And we're going to look at the experience of from the ground, very much as Dorothy has mentioned. So we're going to kind of contrast these three things. Also going to finish with just a few comments on response from the research community, because the issue of the mental health of clinical staff has clearly been very important. And we've been kind of running this live meta-analysis, and some of the kind of insights into the process, I think, are probably equally as relevant as the actual findings. So I'm just going to kick off. And it's worth saying that the mental health of clinical staff during work in a pandemic has been a frequent topic of public concern and is featured in the media. So, we see these sort of headlines. This is from the Financial Times magazine, of all places. A real big feature article on "I just feel broken, doctors' mental health in the pandemic." This is from the New York Times. "Parallel pandemic hits healthcare workers, trauma and exhaustion." This is from the good old Guardian. "They were freaking out. Meet the people treating NHS workers for trauma." I'm kind of making light a little bit of some of these headlines, but actually the public concern has been real, and rightly so. Considering the pressure on the health service. So, but it's worth just thinking a little bit about what are some of the kind of messages behind some of the media coverage, intended or not. So if we look at lots of the media coverage, it's really interesting that the focus has largely been on trauma, PTSD and burnout. And there's been this explicit or sometimes implicit way that this topic has been described. So the idea is that, mental health problems in clinical staff are often described as primarily caused by the pandemic response. So the implicit story is there's lots of healthy, happy clinical staff whose mental health has been devastated by working in a pandemic. And this is despite the fact that we know, and we've known for quite a while, that actually acute clinical staff, particularly those that work in acute medical wards, particularly those that work in ICU, particularly those that work in A&E, have chronic levels of high levels of poor mental health. So actually, the idea that everybody was healthy and happy, and then the kind of pandemic came across and kind of caused mental health devastation is really not really what we understand from a lot of the evidence to date. So it's interesting that this has kind of been the narrative which one would pick up from the media. So early in the pandemic, kind of me and Dorothy put our heads together. I've actually worked with Dorothy before. Dorothy led a really important study kind of developing interventions for patients on ICU to try and prevent PTSD after ICU admission. So when the pandemic kicked off in about April, we kind of put our heads together and thought, what would be a useful contribution in terms of kind of a research approach to some of these problems? And so we thought that actually what we could do is we could do a meta-analysis of all of the evidence on, at the time, staff working in high-risk epidemic and pandemic health emergencies. So most of the evidence, obviously, in April 2020, when we got our heads together, was not on COVID because it had only been around for a few weeks by then. But there's quite a bit of evidence from previous SARS, MERS, Ebola, H1N1 outbreaks and so on. So we thought we'd do a meta-analysis and look at what can we see about the differential mental health impact of working in kind of high exposure versus low exposure roles. We developed this as a meta-analysis and decided to develop it as a live meta-analysis. And what happens with a live meta-analysis is you do a meta-analysis like you normally would that statistically combines all of the results. And then the one you publish, which was initially as a preprint and now as a peer-reviewed paper, is the reference meta-analysis. And then in our case, monthly, what you do is you continue your systematic review, and then you include the results you find, the data you find, in an updated meta-analysis. And so this is what it looks like online. The paper describes the methods for the live meta-analysis. This isn't the kind of the actual URL, but if you go to tinyurl.com/live C19 meta, you'll basically get to this page. It's linked from the abstract of the paper. And you can see down the right-hand side here that we're kind of updating it every month. Okay, so it's base meta-analysis, which has been going on for like 18 months now, and on roughly a monthly basis, we're updating it to include all of the evidence as it comes out. This is kind of from the very latest one. This is from the October update, and November one is due shortly. That just kind of gives you a summary in the abstract of what the latest findings are. You can see we've done this as something called a Jupyter Notebook, which includes the code for calculating all of the results and the display of the results, so you can kind of transparently see what's going on. And every month we add new evidence to the ongoing meta-analysis of differences in anxiety, depression, and PTSD symptoms. We chose those three because those are the three areas for which evidence-based interventions exist. And we look at the difference between staff with high and low exposure to pandemic health emergencies. Obviously now, 18 months later, the vast majority of the evidence included in this are on COVID. And we do a couple of things. We report the meta-analysis of risk ratios and a meta-analysis of Hedges G. So the difference here is risk ratios is all about prevalence. It really tells us how more common is a particular problem in one group than the other. And the two groups we're thinking of here are people with high and low exposure to mainly COVID. And Hedges G, it's just a measure of effect size. If you know Cohen's D, it's a slightly different way of calculating that. It's a bit more appropriate for meta-analyses and allows you to compare the mean difference in scale scores. We include data from essentially studies which use psychometric measures of anxiety, depression, and PTSD symptoms. And so if there's a mean difference, we look at the difference using Hedges D. If they reported prevalence, like so many people scored above the cutoff for moderate depression in this group versus that group, we can do a risk ratio analysis. Everything's open data, so you can download all of the data we use. Everything's kind of produced as open code. It's all in R, it's freely available, it's open license, so anyone can look at it, check it, find any errors, or just take it and develop it and use it to themselves. So just a description of the studies included. So almost all are cross-sectional and report on the acute state, and they're mostly convenient sampled with self-report questionnaires. So I think probably I would say 95% of the studies basically involve everybody in the hospital, all the clinical workers in an area being emailed and asked to fill out an online questionnaire. So this is basically the evidence we have. They're not great quality studies by any means. Large numbers of studies we just simply couldn't include because they didn't report really basic descriptive metrics like means and differences in prevalence. I mean, really kind of basic stuff about the data you're including. So, lots of studies didn't even have this quite straightforward information. And not a single study we included open data or analysis, including NHS studies. So they're really kind of not necessarily kind of well-designed studies in terms of sampling. Typically, their reporting isn't brilliant, and the kind of distribution of data in terms of transparency is often quite poor. These are the country of the included studies. So the first thing you'll notice is actually there's a pretty decent spread between countries around the world. There's a big kind of, the vast majority of studies are included from China, followed by Taiwan and Singapore. You might ask, why is this? Well, if you'll notice, lots of these countries here are the countries which has previously experienced outbreaks of SARS, MERS, H1N1. These and previously published studies in this area, by the way. So these were all countries who pretty much were kind of ready from the get-go to look at exactly this issue, where lots of the other countries actually, had to think and kind of think about, how would we go about tackling this? If we look at the total N, or the number of people included in the analysis, this is from the October update. Actually, there's pretty large numbers. So, for example, for the risk ratio analysis that compares prevalence of anxiety in high versus low exposure workers, there's almost 70,000 people. Depression, 76,000. PTSD, 14,000, and so on. And Hedges G, there's fewer studies report kind of mean differences in the scale scores. But in terms of a meta-analysis, this is actually a pretty large sample just in terms of numbers. So here are the current results. So high exposure clinical staff report statistically reliable differences in the prevalence of anxiety and in depression. So 36% higher levels of anxiety and 23% higher levels of depression, but not PTSD symptoms. So if we look at the confidence intervals here, obviously this crosses zero, possible range of kind of negative 70%, so 36%. But it's probably worth saying that there probably is some sort of signal there. That probably does suggest that there may be some sort of increase in PTSD symptoms, but we can't be entirely sure that that's, to our typical degree of confidence that that's going to be, as reliable as the other measures we have there. However, when we look at the difference in mean scale scores, we see a statistically reliable difference in all of the domains, anxiety, depression, and PTSD. But you'll notice the effect sizes here are tiny. Yeah, these are scaled in the same way as Cohen's D if you're used to them. But, so effect size of 0.14, 0.16, and 0.19. By the way, we looked at evidence for publication bias throughout all of these analyses and found none. So here the difference seems large or small in terms of your exposure to the pandemic, depending on whether you look at prevalence differences or mean differencers. This may be a statistical effect of relying on scale cutoffs. So in other words, if you have scales, let's say like the Beck's anxiety inventory that has a cutoff for kind of like mild, moderate or severe anxiety, it could be that actually the mean difference is quite small, but it just so happens that more people on this side, kind of are above a particular cutoff, thereby inflating the potential effect. But we would actually need a simulation study to settle this, right? In other words, we simulate the data and see whether this is the case. However, because of poor reporting, very few studies report both means and prevalence differences. So it's very hard to test with existing studies. Dorothy.
Okay, thank you, Vaughan. And in fact, thank you for all the work that you've put into this living meta-analysis. I think Vaughan has very much brought the methodological skills, and what I've tried to bring is matching this with some of our experience on the ground. So this is a Sunday Times magazine spread. We invited a reporter in from the Sunday Times magazine to one of our staff support sessions that we were running at UCLH following the first wave of the pandemic. And you can see we all look rather stricken. I'm sure that was clever photography, and it's not the most flattering photograph of myself that I've ever displayed publicly, but I think it was pretty accurate as to how we were at the time. Next slide, Vaughan, please. Okay, so I'm just going to talk about my impression of how staff have been coping throughout the various waves and phases of the pandemic. So this is my experience is very much sort of acute trusts, hospital trusts in London. But I've also spoke to colleagues across the country, colleagues who are leads in staff psychological and welfare services, just to see what our general impression is, because there's not very much, there are not few reports, not very many statistics. So this is just really how we feel things are going. So in the first wave, it was obviously very stressful. We had the fear of the unknown. We didn't really know much about COVID. Doctors didn't really know exactly how we were going to treat COVID in ICU. We didn't know whether we would be infected by the virus, and people were very scared about taking the virus home to their loved ones and vulnerable adults. The numbers were completely overwhelming. At UCLH, we normally have 35 ICU beds, but we had well over 100 patients at any given time. Therefore, ICU nurses and others were having to work in a way that they found really unsafe. You know, whereas you might have one-to-one care of a ventilated patient, you had one nurse looking after 5 or 6 ventilated patients. So that was incredibly stressful for the nurses. Also working in full PPE, which was, really hot, really uncomfortable, and also meant you couldn't really communicate properly either with each other or with the patients. There would be in those early weeks, there were multiple deaths on every shift, including deaths of some of our own staff members being cared for in our ICU. So that was obviously terrible for the staff. At the time, people were saying, they felt very tearful. They were having panic attacks. They couldn't switch off. And when they went home, they had nightmares of what they were seeing in the ICU. And while maybe not flashbacks, as you might expect in PTSD, a lot of people were having intrusive memories of what they'd seen that they just couldn't get rid of. But there were positives at that time. I think in the first wave, there was very much a kind of can-do spirit. We're all in it together. Let's just get on with it. So there was a lot of adrenaline. And it seemed that miraculously all the usual NHS red tape sort of melted away. So people just felt they could take their initiative and, experiment with within the limits of what we knew. So there was just quite a lot of energy there. At the same time, most psychologists in the trust and in the surrounding areas were not able to see their patients. So they were all coming forward offering ad hoc support for staff. And also there was that sense of public gratitude, that at that time the public were all rooting for the NHS staff, sort of fighting their way through the pandemic. Next slide, please. Second wave, one of my colleagues said it was just horrible. Staff really felt exhausted, and there was a general feeling, we just can't go through this again. We can't do what we did in the first wave all over again. There was quite a lot of anger amongst staff at the government, maybe for not having done more to prevent the second wave, at the organisation for just expecting us all to go through it again, and at the public maybe for not being as cooperative with mask wearing and all the rest of it. So people were quite angry, even a bit bitter. At the same time, usual business had to be done. We couldn't just say, right, we'll close everything down, no more clinics, no operations. We were trying to keep up, quite rightly, with all the regular work. And somehow the usual red tape had really come back with a vengeance. So we felt a lot more monitored and targets and the rest of it. There were still positives this time, of course. Everyone had more experience with the virus. More was known about treatments. More was known. We were able to slot back in more quickly to the usual ways of work, or to the unusual ways of working. Staff had been vaccinated by this time, most of them, and also the vulnerable had been, so that perhaps led to some optimism. But also the risk to staff well-being had been recognised, and initiatives have been funded and planned, if not necessarily happening yet. Next slide. Okay, so what about now? My colleagues, as I say, who work in supporting staff in occupational health, the general impression is that staff are mentally and physically exhausted at this point. COVID-19 hasn't gone away 18 months later and probably won't go away. It's here to stay. We've all been urged in the NHS kind of work harder, work longer. And I think while everyone's happy to do that for a few months for what seemed to be maybe a short-lived outbreak, but now that way of working seems to be here to stay. So it's a lot more tiring to keep doing that for sort of year in, year out. And unfortunately, there's been an increase in violence and aggression from the public towards NHS staff. So one colleague said, "Oh, last year you clapped for me, now you punch me in the face for asking you to wear a mask in the waiting room." So incidents like that have happened, which just makes things all the more harder for the staff. Next slide. What are the responses to that? Well, as we've seen in our meta-analysis, but also in a lot of local surveys and services, there's a lot of psychological distress and a lot of people talking about burnout. There are a few cases of PTSD, but really that's not what we're finding is the main issue among staff on the ground. We're also finding what I've called here presenteeism, work to rule, people who were previously really energized, can-do people, now just feeling they haven't got the energy to bring, and we sort of turn up to work and do what we have to, but maybe not going the extra mile, as we're always urged to do. And staff psychologists have found they've been called in increasingly to mediate for relationship breakdown, even in teams that were formerly very cohesive and very strong. Now everyone's nerves are frayed at the edge, and people are just not getting on so well, and teams are becoming more dysfunctional. This is the bit where I found it hard to get any hard and fast figures, but the general impression is that sickness rates are definitely up, and particularly because of stress, work-related stress, as well as COVID-related issues such as having COVID or self-isolating for COVID or having long COVID. And there is a feeling that maybe some staff are more comfortable to report long COVID rather than stress. A lot of people are talking about leaving, thinking about leaving, or have left. People are saying, is this really what I want to do for the rest of my life? And questioning their values around that. Some people are just going into easier roles off the front line, maybe working in an outpatient clinic or in a community. And a lot of people are thinking about early retirement. And recruitment, there was already, as I'm sure you all know, a big existing problem with recruiting clinical staff, particularly nurses. And I think the pandemic has only just exacerbated that. Next slide. So, as one of my colleagues said, the pandemic has poured water through the holes in a broken system. And I think this is what's kind of showing through in our study. NHS staff were already extremely stressed and, often working in really poor conditions. And perhaps the pandemic has just sort of exposed that to the public and to ourselves. It's kind of just brought the whole thing to the fore. So there's always a national staff survey done in the NHS, and in 2019, 40% of NHS staff reported that they had been ill with work-related stress, which really is a phenomenal amount. So this was pre-pandemic. Since the pandemic, it's gone up to 44%. So it has increased, but the difference is not that huge. We already were at 40%. A lot of staff now are just talking about how poor their conditions are. And there's also, unfortunately, an endemic problem in the NHS of bullying, harassment, and discrimination. And in that last survey I talked about, 2019, I think 31% of Black and minority ethnic staff said they felt there was no equality of opportunity in the NHS. So these are some of the sort of issues underlying what we're seeing now, that we have now been just exacerbated. It's welcome that there has been new recognition that staff do need rest breaks, toilet breaks, access to water and food during a busy shift, somewhere to go and relax, compassionate management that supports you, psychology support if necessary, as well as education and development opportunities. It sometimes seems incredible to me that we've still got to talk about, meeting those basic needs, that you do have staff in the ICU that just find they can't get off for a toilet break, people that say, I didn't get a drink of water all day, so they're really dehydrated by the end of the day. So sometimes they say, look, I don't really want your resilience programs and your well-being initiatives. What I actually want is these basics. If I feel really stressed, I want a nice, calm, peaceful place to go and sit and have my break. But as I said, it's good that, people are starting to recognise that. But unfortunately, it's good in some trusts, but the provision still lags in many trusts. Many NHS staff are still working in fairly dismal conditions, unfortunately.
So I'm just going to finish with a few words about the global research response. One of the things that really impressed me about the research response to COVID was that in many fields of medicine that have traditionally been very competitive, there was a sudden turn to sharing data, creating shared standards, building on each other's work in a very open and collaborative way. Unfortunately, this didn't seem to have happened to any of the mental health research in this area, and I would say mental health research tends to lag in this area anyway. But given that we found not a single study that has open and shared data, I think this is a real problem, considering that actually the mental health and indeed well-being of clinical staff is really an absolute keystone of the clinical response to COVID. So the response from mental health researchers has been siloed, information hoarding and ad hoc. I have to say it's a real pleasure being on the same kind of bill as the COVID life study earlier on, because I know that's not specifically on clinical staff, but that's a really good example of people doing it right. Open data dictionary, really transparent. It's really fantastic. So it's not that it can't be done. It's not that there is something special about mental health, which means that this sort of transparency and openness and coordination is impossible. It's really the fact that we need to think about our structural responses to these sort of global issues that are common in other fields, because I really do think it lacks a little bit in mental health. And really, the experience of doing this live meta-analysis has really highlighted that. So just to finish with some conclusions. So the impact of the pandemic on mental health is likely to be quite variable. However, even if COVID only increases the on-average burden by a small amount, this will be in addition to already high levels of chronically poor mental health. Supporting mental health and working conditions in clinical staff, particularly in acute staff, is long overdue. But really, mental health, I think we both agree, is too narrow a lens on its own through which to see staff well-being. So has this been a useful exercise? Me and Dorothy have spent the last 18 months working on this, updating it. Actually, has doing a live meta-analysis been useful? Well, it's kind of hard to say, actually. I'm a little bit disappointed to say. There's no clear evidence it had much impact on policy beyond some broad suggestion of taking mental health seriously, which of course is important. But actually, more methodologically sound longitudinal studies are likely to be key. These are indeed ongoing. I have to say they do not fulfill our criteria of being kind of open and transparent and making the data available and so on. But I think one of the main conclusions that we've come to with regard to this kind of methodological approach is that we're probably contributing to the response in the next pandemic rather than this one. Thank you very much.
within the Scottish context, also research that has compared clinical as well as non-clinical staff, the impact on social care workers has been an area of increasing concern.
I'm sorry, was that a question? We didn't hear the beginning of it. It was cut off, unfortunately.
Okay, no problem, sorry. Are you aware of data collected within the Scottish context? Any research that's compared clinical as well as non-clinical staff, because the impact on social care workers has been an area of increasing concern?
So certainly there have been no studies which would report data in a way that we would include in our meta-analysis. However, that doesn't mean to say that they haven't been done, because as I mentioned, a lot of the studies have been excluded because they didn't report stuff in a particular way. However, what you mentioned is really important, and a lot of these studies just compare healthcare staff in general, and they do a large trawl of healthcare staff, usually within an organisational institution. Okay, so contact all of the doctors within a hospital, or all of the healthcare staff in what would be the local equivalent of an NHS trust or something similar. So I know of no specific studies which have looked at healthcare staff in Scotland, or indeed other places actually. No, that's work to be done as far as I understand.
Actually, there is a study. I think there is a big study ongoing, which I think looks really promising. I think it's called the Candid study, and that's happening. That's basically, I think it's mainly about IC workers. So that's some colleagues in Aberdeen and other centres, really good researchers doing a big multi-site trial. And I think what's interesting is they're looking at other outcomes other than the sort of anxiety, depression.
I'm sorry, Dorothy, you've frozen there.
Other than just the mental health outcomes.
I'm so sorry, we missed a bit of that, Dorothy. You froze. Just the end bit.
Sorry, yeah. Did you hear? I don't know which bit you... I'm just talking about the Candid study, which is a multi-site trial study looking at staff stress in Scotland. And I was saying that they were using better outcomes than just anxiety, depression, PTSD, but they're looking at outcomes measuring work-related stress specifically, which I think is the most relevant here.
Okay, we are again short on time, and we could talk about these interesting issues for a lot longer, I think. On the chat, there are a few questions there. I'll just summarise some of those thoughts, if that's okay. A couple of comments just about the longer standing pressures that the NHS is under and how COVID has exposed that, and general frustration about the impact that has on the delivery of quality care. That's something that we see in mental health staffing particularly as well. Eileen Hay has said, why won't the government pay more attention to what's going on for the staff? There seems to be an undercurrent of dismantling the NHS, which is so worrying. And a further comment, which goes back to the previous talk, actually. So, could I ask the presenters just to reply to any outstanding questions on the chat there, because we're out of time. We're now going to move on to posters, and I think the poster video should start shortly. The link, anyway, is on the chat, and then we'll have a lunch break just after that. Thank you very much to all our presenters for this session.
Thank you.